couple of people staying to the last one. Yeah, it's a very busy day for me. It's my fourth activities of the day. So I will let Professor Shiong start the session. I hope I will not sleep during the session. All right. So Professor Shiong.
Thank you so much to stay to the last session here. And so the first speaker is Dr. Kao Tung-Wei. And Dr. Dong got his PhD from the National Taiwan University Institute of Clinical Medicine. And he's the attending physician in the Tri-Service General Hospital. And he's also the associate professor at the National Defense Medical Center. And today he's going to talk about body composition and biomarkers among different muscle health statuses. Results from the DYNASTY-TSGH Tri-Service General Hospital study. So let's welcome Dr. Dong.
Yes, thanks for Professor Shiong's introduction. Ladies and gentlemen, and welcome to this presentation. And I'm very appreciate your perseverance to keep to the final session. My topic is about the muscle health status, and focus on the body composition and some biomarkers. So, sarcopenia is a term released by the Iron Rosenberg since 1989. And it focused on the age-related decrease in muscle mass. I did not mention about the muscle function. And almost 2 decades later, the European Consensus of Working Group on Sarcopenia in Old People just released a consensus of sarcopenia, the diagnosis criteria, and focus on the 3 parameters. One is grip strength, and the other one is gait speed, and the third one is the muscle mass. And define the cut point to represent the low grip strength or low gait speed or low muscle mass. And 4 years later, Asian Working Group of Sarcopenia also released a consensus. It's also focused on the same parameter, the grip strength and the gait speed and the muscle mass. But they defined definitely the cut point for the men and the women, and the gait speed lower than 0.8 meters per second. And they suggest to use the DEXA or BIA to measure the appendicular skeletal muscle mass. And in the beginning, from the 2010 and 2014, European Working Groups of Sarcopenia, I defined a special term to describe the muscle health status. If older people just with muscle mass loss, it's called pre-sarcopenia. But older people have muscle mass loss accompanied with muscle strength decline or physical performance impairment. It's called sarcopenia. And even old people have triple loss of these 3 parameters, it's called severe sarcopenia. But in clinical practice, you can find some people, they have low muscle strength or low physical performance, but they have reserve of their muscle mass. How could we define this phenomenon? Actually, in 2008, Dr. Clark and Dr. Bernini has released a special term of dynapenia. It's just focused on age-related loss of muscle strength, but reserve of muscle mass. And it also mentioned about that sarcopenia is not equal to dynapenia. In 2018, the European Working Group of Sarcopenia revised the consensus. They also awareness of the muscle strength is most important. So they provide flow chart to find out the candidate of sarcopenia. They use the SARC-F first to screen the possible candidate of sarcopenia. If the SARC-F is positive, they will perform the muscle strength, grip strength, or the chair stand test. If the muscle strength is declined, they will set up a specific term is a probable sarcopenia, which means low muscle strength is an indicator for probable sarcopenia in the future. And if they perform the muscle quantity using the DEXA, BI, or CT, or MRI, if it is positive, they have a muscle mass loss, they will confirm sarcopenia. And they perform the physical performance, and if it is positive, poor performance of physical performance, you will call severe sarcopenia. So this special term is probable sarcopenia, which means loss of muscle strength in older people. And also in the AWGS, they also revised for the second version. They also released a special term of possible sarcopenia. They also screen by the SARC-F or SARC-CAF, and then perform the muscle strength examination, such as hand grip strength or physical performance, 5 times a chair stand test. If it is positive, it's called a possible sarcopenia. Or even either a probable sarcopenia or a possible sarcopenia, which means muscle strength loss. And then if the muscle strength loss first, they will perform a diagnosis to confirm the sarcopenia or severe sarcopenia by muscle mass measurement and the physical performance measurement. So from this flow chart, from these guidelines of sarcopenia, we can focus on 2 parameters of muscle health status. One is muscle mass, and the other one is muscle function, muscle strength or physical performance. So these 2 parameters could divide it into 4 categories of muscle health status. The first one is if old people have muscle function decline or muscle function positive, and then you will perform the muscle mass examination, muscle mass positive or muscle mass negative. So even older people with a positive muscle function and positive muscle mass, it's called robust. If older people have normal muscle function but loss of muscle mass, maybe called pre-sarcopenia from the consensus of Europe Working Group of Sarcopenia in 2010. If older people have low muscle function but they have reserved muscle mass, maybe you can call it possible sarcopenia because it's just the loss of muscle strength. And if old people have double loss in muscle function and muscle mass, it's called sarcopenia. So we can divide it into 4 categories to describe the muscle health status in older people. So in your study, I would like to answer a question because old people will transition from the robust to sarcopenia, from double positive on muscle mass and muscle function to the double loss to the loss of muscle mass and the muscle function. During this progression, either they will go to the dynapenia pathway or pre-sarcopenia pathway. Either they will lose of muscle mass first or loss of muscle function first. And then eventually, perhaps they will go to the sarcopenia, the endpoint. If we set endpoint is sarcopenia. So I set up a long-term follow-up study. I call it dynapenia and sarcopenia in Taipei City since 2015, just to want to observe the transitional trajectory from the robust to sarcopenia. So this method is study design is a longitudinal study since 2015, and we enroll the old people in the community age older than 65 years old. And we have annual health checkup in the Health Management Center. And this is conducted in the Tri-Service General Hospital. So we use the consensus cut point to measure the grip strength and gas speed and the muscle mass. And this is the schedule for measurement. On the baseline, we measure the BMI and body composition, waist circumference, and the fat component, and the grip strength, gas speed, and clinical events. And annually, every year, we follow up their body composition and muscle function, and to observe their clinical events, such as fall or hospitalization or ER visit or disability or something like that, metabolic syndrome, every year, and continue to follow up until now. And we have some exclusion of participants. If old people are under regular hemodialysis or congestive heart failure or the poor cognition, or if they have cancer under treatment, or if they experience a joint pain or chest pain during exercise, we'll exclude it. And we'll have a structural questionnaire to obtain health behavior, physical activity, and overall the health conditions, including physical activity. Because we are interested about body composition, so we focus on the obesity profile, including body mass index and the waist circumference, body fat mass, and body fat percentage. And especially we include the fat to muscle ratio, because we want to understand if the fat and muscle have some interaction to affect muscle strength or muscle mass. The aim of this study is just to understand the muscle health status, the four groups, what's the difference, or what's the prevalence and the distribution among old people. And the other one is to measure the body composition in different muscle status. And also the impact of muscle condition and on clinical events, just the fall and the metabolic syndrome and something else. We also examine the biomarkers related to the muscle and fat interaction. So first, I present the preliminary data. So this is the baseline from 2015. We enrolled about 765 participants in our center. You can find that all of them are almost a robust population. And the second one is the prevalence is dyspnea. And even higher, the prevalence is even higher than the sarcopenia. And the pre-sarcopenia is the last one in prevalence. And we can also focus on the special condition is their body composition, especially their BMI and the waist circumference and fat mass and body fat and the fat muscle ratio. In dyspnea group, they are the higher obesity profile among the four groups. And especially in the dyspnea group, they have a higher prevalence of metabolic syndrome and hypertension and some chronic disease. And the pre-sarcopenia is the reserve of muscle function, but they have muscle mass loss. They have the relative leanness compared to the four groups. And you can see the picture. We describe the obesity profile, such as the BMI and the waist circumference. You can see the dyspnea group has a higher obesity profile than the sarcopenia and pre-sarcopenia. And this is body fat percentage. body fat percentage and the subcutaneous fat is also show the highest prevalence in the dynapenia group, and the lowest one in the pre-sarcopenia group. And this is fat to muscle ratio. Fat to muscle ratio indicates obesity, another index to represent the obesity. It can also show that dynapenia group has a higher prevalence of fat to the muscle ratio. So we also examined the 4 risk among the 4 groups to test the clinical impact on different muscle health status. You can see we set the robust group as the reference, and the dynapenia group has a higher 4 risk than the other groups, than the sarcopenia groups. And the pre-sarcopenia groups has the lowest risk to 4. And we also examined the metabolic syndrome risk among the 4 groups. You can see that dynapenia groups, loss of muscle strength, they have a higher obesity profile, so they have a higher risk for metabolic syndrome than the other groups. And pre-sarcopenia, because they reserve their muscle function, but just the loss of their muscle mass. So they can reserve some function, and they may have the least metabolic syndrome risk among the 4 groups. So the brief summary in this presentation is dynapenia, loss of muscle strength, but reserve of muscle mass, has more fat in body composition, and they have higher risk, higher fall risk in clinical events, and higher risk for metabolic syndrome than sarcopenia and pre-sarcopenia groups. So we think that muscle strength is more important than muscle mass in clinical events during aging process. So during aging process, we also encounter body composition change. When we are in young age, we have a high amount of muscle mass and high muscle function. And during aging process, when we're getting old, we have body composition change. Maybe we have a shrinkage of our muscle mass and loss of our muscle function, but our fat mass is increasing. So the different body composition means we have some interaction between muscle and fat. So in the previous study, they have summary some parameters to indicate muscle mass and adipose tissue. And the left one is normal status. Normal status means we have a good muscle mass and moderate adipose size. And this is the parameter, like biomarker like irisin and IL-6, IL-15. And the other one is adiponectin. This is a good marker to reserve a small amount of adipose tissue. And the right one is bad condition, which means the muscle fiber is shrinkage and the adipose side is getting large. So which means the biomarkers to interfere this condition is negative biomarkers such as leptin and myostatin and some interleukin-6, just like that. In our study, we just, because limited budget, we just performed some biomarker to examine the differences between these 4 groups. But almost all the biomarkers show a negative, non-significant association, just leptin. So I just show you the data about leptin. And leptin is different by gender. Female subject is higher than the male subject, maybe because we are modified by the sex hormone. And so we separate to describe these findings. The first is male groups, and we divided leptin into the quartile into the quartile. And you can see the quartile 4 is the higher leptin level, and the quartile 1 is the lowest leptin level. And you can see some parameters show significant differences, including BMI and waist circumference and SMI and gas speed. The higher leptin level, which shows a higher amount of BMI and the waist circumference and the rapid gas speed. And also in the obesity profile, you can see if people with a higher leptin, they will have a higher fat mass and fat muscle ratio, and they will have higher risk to have metabolic syndrome in the men groups. And also in the female groups, we also divide it into the quartiles to describe different parameters. It also has the same findings, including a high leptin level will increase the body mass index and the waist circumference and SMI, and they will have a rapid gas speed. And also in the obesity parameter, the higher leptin level will increase the body fat and the fat muscle ratio. And also have a higher leptin level will increase the risk of metabolic syndrome. We also examine the association between the leptin level and the muscle mass and the grip strength and the gas speed and some obesity parameters. It shows a positive association between leptin and the SMI and the waist circumference and the fat mass and body fat percentage, but negative association to the hand grip strength and the gas speed. So because leptin is associated with muscle mass and fat mass, and negative association to the hand grip strength and gas speed. So we collect it together to define the low muscle strength and reserve muscle mass. What's the difference between the association to the leptin level? So we define the logistic regression to observe if a higher leptin level will increase the risk of thalassemia or sarcopenia. You can see because leptin level is different in male and female, so we discuss it separately. So in first table, you can see the male subject. We compare the highest leptin level to compare to the lowest leptin level. You can see it shows a positive association. Also show a dose response effect. Compared to the lowest leptin level, the highest leptin level will increase the risk of thalassemia. The trend is significant. And in terms of sarcopenia show a reserve association, which means a higher leptin level will decrease the possibility of sarcopenia. It's so dose response reaction. And it also shows these findings in the female participants. So in this experimental summary, we can see the higher serum leptin level will increase the muscle mass and the fat mass, but will decrease the hand grip strength, gas speed in both genders. And leptin is maybe a status of good nutrition, so it will increase the risk of thalassemia in both genders. Maybe they will decrease the risk of sarcopenia because sarcopenia may be a status of low muscle mass, which means malnutrition. So in discussion, obesity and muscle function. So in the obesity history, if older people have a long history of obesity, they will have decreased hand grip strength. And in older people with a higher body fat percentage, they tend to have a loss of hand grip strength and work speed. And then the lower body fat percentage in the previous study. And also we find that in the previous study, along with the age increasing, we have intramuscular adipose tissue increasing. And the higher fat, which means you have the lower maximal torque of your leg. You have a lower fat, you will have a higher maximal torque of your leg force. So in addition, we introduced the fat-muscle ratio because in previous study also mentioned about this. And in Korea study, they found that fat-muscle ratio increasing, the hand grip strength will decrease. And also in California study, they also find the same results. So in our study, we demonstrated the fat-muscle ratio. In dynapinia status, they loss of muscle function. But reserve muscle mass, they have fat muscle ratio increasing, but they have loss of their muscle strength. And in pre-sarcopenia, they are leanness, so they have a low ratio of fat muscle ratio, and they have increased grip strength and gas speed. So we can think that fat muscle ratio and muscle function is show a negative association. Maybe a fat will interfere with the muscle function. So in leptin, fat and muscle condition, in the previous study, leptin and fat and muscle, and the longitudinal study, leptin can increase the muscle, the trunk fat and their body fat. And also in the animal study, the leptin administration in mice, they can decrease the gradation, the protein degradation, and increase the muscle mass. So they can increase the muscle mass and the fat mass. But in muscle function, leptin is like a good nutrition status. So in previous study, they also show leptin concentration is positive associated with cholesterol or albumin, and negative associated with the malnutrition score. And leptin and muscle function also show a negative association in the previous study, especially in men. And leptin in skeletal muscle mass, skeletal muscle cell, they can increase the skeletal muscle cell and to increase the fatty acid oxidation. So they can to accumulate, if this pathway is blocked, they can accumulate deposit of fat in the muscle cell. Maybe it will interfere with their muscle function. So in previous study also showed that high level of leptin will in the obesity condition will increase the insulin resistance and the fatty acid oxidation will decrease, which means excessive lipid will accumulate in the skeletal muscle mass. So the muscle quality and the muscle strength will decrease. So the leptin level, which means hyperleptinemia, which means leptin resistance, because like the insulin resistance, your leptin in the obesity condition, they will have some resistance to blunt the signal transduction. So they will have decreased the fatty acid oxidation in muscle cell. So the intramuscular fat infiltration will increasing. So the muscle quality may be decreased. So in conclusion, in our study, we can see the prevalence and obesity and the fall risk and the metabolic syndrome, all of these parameters, dynapinia, loss of muscle strength, are worse than the sarcopenia groups. And during aging process, fat will again accompany with muscle loss, and this will interfere with muscle function, and it will make the muscle function decline. And leptin may be a status of a good nutrition status. So muscle mass and muscle function, muscle mass and fat mass will increase, and that may be decrease the muscle function because of leptin resistance. So that may be a status malnutrition. So maybe leptin maybe decrease the risk of sarcopenia and increase the risk of dyspnea. So I also want to acknowledge the National Taiwan University and Child Service General Hospital, and also the funding from the Ministry of Science and Technology. And I have to thank all the participants in this study. Okay, thank you very much.
Thank you, Dr. Kao. To save your question to the end of this session, and so let's welcome the second speaker, Dr. Shuichi Obuchi. And Dr. Obuchi got his PhD from Kitasato University, Japan. And he's now the chief researcher in the Tokyo Metropolitan Institute of Geriatrics and Gerontology in Japan. And also he's the adjunct professor and the director of the Management of Frailty, Faculty of Sport Sciences, Waseda University. So and he's going to talk about an attempt to develop a digital biomarker for frailty. So let's welcome Dr. Obuchi.
Good afternoon, ladies and gentlemen. It's my pleasure to having you presentation. I'm very thankful to NHRI. Today, I would like to talk about our attempt to develop a digital biomarker for frailty with these kind of wearable devices. Neither of our members did not have any financial support from the institute, other institute. Today, I would like to talk about a little bit, briefly explain about our recent researches, then the attempt to use this kind of measurement system to detect the frailty and non-communicable disease. And this project is done by our research institute and geriatric hospitals. So we are collaborating with the doctors and scientists. Let's talk about the background a little bit. This is the early strong predictors of decline in instrumental activities of daily living, which means 4 years IADL decline. What kind of factor is most closely related to the IADL decline, including almost all of the comprehensive geriatric assessments. It's including hand grip strength and the standing time and walking speed, maximal walking speed and time up and go time, and also the oral function. And here is a repetitive swallowing test. And here the dietary variety score, geriatric depression scale, and WHO-5, and also a mini mental state exam and Raven social network scale, which means it covers most of that aspect. And we found as the yellow here that these kind of the walking related indices is the strongest predictor for the 4 years decline in IADL. So maybe that if the researcher, you or the researcher of the frailty field, you all agree with the walking speed is a very important factor to predict predictor. But the problem is to measure the walking speed, we need to the certain kind of walking path, and also we need a special laboratory technician who measures that the walking speed. the nurse or others cannot do that. So that's the problem, so that the clinicians did not use that kind of the walking speed for the everyday diagnosis. So what we do is we try to use this smartphone system, whether this system can be measured like walking parameters without any intention of the subject. Actually, this the smartphone has a step counter in the very basis of the OS level, and also this one has a GPS system. So if we understand the person walking steadily, we can measure that length of the walking, and also we can measure the speed, time of the walking, so that we can calculate walking speed and step length and cadence, and the cycle as well. So in this system, the application system the monitors the step counters every minute, then find out if they are walking or not. If the system understand it's walking, they ask the GPS system on, then every 20 meters of straight walking, if the person did not walk straight, it's omit that the data. Every 20 minutes of walking, they measured, they calculate the walking speed and the step length and so on. Then after that, all correction, the application send those data onto the cloud in once a day. Using this system, we did a series of the researches, whether this is compatible to the gold standard measurement, which is using stopwatch. We found 84% of agreement with the smart stopwatch measurement, and also I thought that we did not know about the distribution of this kind of unintentional walking. So someone, in a hurry, it should be more faster. But if they have a time or they walk with the children, they should have a slower speed. So the distribution can be a two-fold or any distribution. But so I did about 1,000 people asking use this system, then compare their distribution of the walking speed. Then I found that the walking speed is more normal distribution type. So that if we see that the mean walking speed, you can tell that their regular walking style. So I thought this can be used as a biomarker of the person. It's not affected so much by the social or environmental factors. Then I did the retest reliability, and also and then I found a very good retest reliability of the system. Then move on to the I get the reference value. I had 15,000 participants using this system, age from 20 to over 80 years old, so that I calculate that each of the group, the standard, I measure that they published that reference value of from 20 to 80. Then I just wondering if this system can be used as a frailty measurement or not. So I did a measure. I asked our cohort person to use this system, and then the value from our system could be explain the frailty category or not. And it is about good as the stopwatch measurement. And also, I did some intraday validity and seasonal validity. The interesting thing of seasonal variability is walking speed is highly related to the temperature of the environment. Do you think which is faster? The colder is the faster, or the warmer is the faster? That I found is the colder the faster. So that is kind of regulated by the midbrain function that I believe. So I did that kind of things. So I'm more sure that this walking speed measured by this system could be biomarker. Then, after the pandemic of COVID, I did some clinical researches about whether they changed their activity or not. Now, so I'd like to move forward to use this kind of system to the frailty. But frailty, as you know, frailty is not the concept of physical functioning. It also should include social functioning and others, mental function, cognitive functions, oral functions as well. So we attempted to compare this kind of cohort study to this kind of the lifelog data. We used the smartwatch here and asked the participants use the ankle band type of walking speed measurement. All these data go to the smartphone. Then subjects were asked at least 3 months of using this system. In fact, the study is started from last year. 60% of the participants still using this system, although they can be withdrawn after 3 months of the research. Then this part here is the cohort study here. We did a cohort study every once in a year, but the problem is maybe you encounter that kind of problem. If you ask the community dwelling person, there is not so many frail person or MCI persons. So this time we have a frailty outpatient clinic in our hospital. So we include that they are registered person with the regular cohort study. So we have about 600 the cohort the participants, and also we have 500 of outpatient. Of those, we are asking whether they would like to use this kind of a system or not. And we had about 1,200 of participants accepted to use this system from the about 7,000 of the possible participants. So if you're looking at the difference between user and non-user with the assist of some statistical analysis, you can compare whether this kind of system is effective or not as well. Then, using these kind of data, it's huge data, so I cannot calculate by my hand. So I asked the AI system whether they are frail or not. So the main outcome is physical frailty, cognitive frailty, and social frailty, and also non-communicable disease. And good things of the smartwatch is not only measure the physical functioning, but also measure some social aspect, which is verbal, the length, duration of conversation time, conversation duration. We have a number of steps, gait speed things, and body temperature, and energy expenditure, and heart rate, yeah. And also, to send the data to the crowd, some of participants did not have the smartphone. So I asked the gateway to send the data from these devices to the cloud. On that, the gateway, it has environment sensors that can be tell how cold and how much pressure, how much CO2, and so on, how illuminance, how bright it is. So I think combined with this kind of information, we can understand some aspect of social functioning as well. And these are the health outcomes. This is more common, so just skip this part. So we have we asked the person asked to use the device is our 1,200. Of those, about 74 persons are agreed to use this system. Within those, about 54% is robust, and 62% is pre-frail, and 7.7% is frail. So we use that the frail outpatient clinic, but still we have a small number of frailty persons. We use the CHS criteria for determining the frailty. This is the overview of data collection. Subjects are asked to use the devices about a year, but if the person did not want to use it, they can withdraw after 3 months. Then every year we are going to have a cohort study. We are now here. And after that, we are hoping they still continue to use this system. This is a data from these participants of the 3 months of data recordings. You can see here, heart rate is not different between robust, pre-frail, frail, but energy expenditure, they don't move so that the frail person has a lower energy expenditure, but sleep is much more, but talk, this is the interesting part, conversation with the person is, the frail person is much higher. This is, it is not I expected, but maybe a frail person would like to communicate somebody, but also I found, I tried to look at the hour by hour analysis. The talking time is started at 7 o'clock and 12 o'clock and about 6 o'clock. It's increasing the talking time. So that I think that these frail persons have to have some kind of assist for eating or something, so they communicate with the carers. That's my understanding, but I don't know that's true or not. But you can see the significant difference between groups. In the female, there is not so many difference, but the tendency is the same. This is the traditional type of analysis of this kind of data. I think this is the more focused on amount of the activity. So combine these data and compare the mean value of these things, we found that significant difference. I put the color on the significant difference. So activity calories and metabolic rate, sleep duration, and total steps are significantly different. Sleep duration is increased. But I use this kind of the data put into the machine learning. But as you see here, the accuracy of these data are less than 60%. Maybe the conventional research had a much higher accuracy, but they don't use the validation study. They are using same data set, making the model and then validate with the same data set. So it's overestimate accuracy. But this types of the analysis, we use the independent data set, that it was less than 60%. So to me, the traditional type of analysis is not enough. So what I do is we call this is tapestry analysis. This is my data here. This is walking the habit. I get up early in the morning at 6 o'clock, then move lifestyle walking, which means I do some the household works, and from the 6 o'clock to the 8 o'clock, then go to the job. So I have a steady walking here, and then get to the research institute and sitting all the time. Then in the lunchtime, I go out, things like that. If we see this kind of the character pattern, person by person, we can understand more their social pattern or things. So that's the idea. So I put the green light shows the walking over 1.1 meter or higher. And this is from day 1 through day 30. This is the combination of 30 days of measurement from 0 o'clock to the 24 hours. So looking at these kind of the measurement, the picture, you can understand their pattern easily. So using this tapestry, I did more the deep learning. This is a typical type of the tapestry data. Robust individual has a clear signals, and this case B has a very intense the lights in the morning, so he may walk every day. But see here, frail persons did not have much lights, and also the pattern is odd. using that information, just we start the research last year, so we did not have a good enough time to analyze. So I just a quick try using LessNet 50 and using sleep, and then whether it can be classified frail, robust, pre-frail. Then the result is much better than the ordinary type of analysis. Ordinary type of analysis could not distinguish between frail and pre-frail. But this type of analysis mostly distinguish frail and robust. But robust and pre-frail is, I think it's confusing the definition, I think. There can be convert easily. So right now, we are not have enough accuracy of that system, but I would like to do that things more. This is the result from that the deep learning. The actual is the real measurement and predicted it from the AI. This slide shows the actual measurement is robust, but the AI predict as a pre-frail. But see here, in this pattern, you can see the person sleep in the daytime a lot. So the actual measurement is 0, but predicted to the frail. So maybe AI understand more than the things. I did some other group-based trajectory modeling. Like if we do that kind of analysis, we can do that if a person use this system. This is the from 100 days, 3 months, and then if we look at the trend of the person, if the person increased, let's say step by day increase this way, that means they are affected by this kind of the system. So you can also understand they are tolerate with, they have ability to change their life or not. So conclusion, we are doing in the middle of the research, but we would like to do to find several aspects of the frailty. Of course, if we measure this kind of motion analysis, motion activity analysis devices, we can understand the quantity of the activity. But if we use that kind of tapestry analysis, we may understand the quality of activities. And also, our challenge is maybe I need to find the social aspects as well. So that's our attempt. Thank you for your attention.
Thank you very much, Dr. Obuchi. So we'll still save your question to the end of the session. And so then next, Dr. Zhang will chair the next 2 speakers.
So we will welcome Professor Wei Xiong Lin. He's from Singapore. Right now, he's the director of Institute of Geriatrics and Active Aging at Tan Tock Seng Hospital, Singapore. And he's also the associate professor of Lee Kong Chiang School of Medicine, Nanchang Technological University. And then today the talk is osteosarcopenic obesity insight from the Jerry LABS2 study. Let's welcome Professor Lim. Thank you.
Yeah, thank you very much for the kind introduction. Thank you also very much to NHRI for this very prestigious invitation. It's always a delight to come to Taipei. And today I'll be sharing insights about osteosarcopenic obesity, or OSO, using insights from the GeriLabs 2 study. Shown here are my co-authors, and I have no financial disclosures to declare. So in my talk, I'll first give an overview of OSO. Then I'll share some results from the GeriLabs 2 study, and I'll close off with some reflections. Alterations in the bone-muscle fat interface is one of the changes that we see with age. And what this does is that it can lead to the characterization of the triad of osteoporosis, osteopenia, sarcopenia, and increased adiposity. So these conditions can kind of combine to give rise to different combinations of tissue derangements. So if we have overlap syndromes such as sarcopenic obesity, there will be fat and bone. Osteosarcopenia would be bone and muscle. And this theoretical entity of osteopenic obesity, which is the bone and fat. And OSO occurs when all three combine to give that triad. And it is believed in the conceptual model that this is the so-called most advanced stage in the bone-muscle fat interface, arising either from age or individual comorbidities. So why is OSO significant? I think in terms of pathophysiology, it has its origins in the mesenchymal stem cells. In younger age, the MSCs show a preference for differentiation into either the myocytes or osteoblasts. But with age, and especially in the presence of inflammation, the MSCs increasingly differentiate into adipocytes. And the ectopic deposition would give rise to, for example, the increase in waist circumference, deposition to visceral tissues, and of interest today would be the deposition into the muscle and bone. This dysregulation of the fat-muscle-bone crosstalk is occurring in a pro-inflammatory milieu and in a background of increased insulin resistance, which is driven really by the release of adipokines, myokines, and osteokines to give rise to the triple whammy of decreased muscle mass, decreased bone density, and increased adiposity, which over time result in the OSO syndrome. So the interest in OSO arises because there is this thinking that the combination of these three may actually result in worse outcomes than individual conditions. So in this study, OSO actually has worse in terms of weaker hand grip strength and lower gait speed compared with the non-OSO obesity phenotypes. And in the Frailty Max study, OSO is associated with a 2 to 5 times increased odds of frailty compared with non-OSO. When we look at the studies, there's quite a wide prevalence, ranging from about 6% to 25%. Reasons that have been cited for this variation include the fact that different operation definitions has been used, especially for obesity and sarcopenia domains. The characteristics of the study population in terms of the social demographics, the frailty status, and the study setting. So studies which recruit older subjects and with females tend to have higher prevalence of OSO, and social cultural factors may also be at play. So this is data from the Yishun study in Singapore, and I would like to draw your attention to the dotted lines for OSO and ignore the bold line for OS. So there are three trends worth highlighting. The first is that the prevalence of OSO increases with age. And this age-associated increase in prevalence is dependent also on the definitions used. So if we were to use percent body fat, this would result in a higher prevalence compared with the use of the fat mass index, and you can see that across the two panels. When we look at the sarcopenia definitions which use the appendicular lean mass-based definitions would result in higher prevalence compared with those using the APGS 19-based definitions. However, there are gaps in terms of our current understanding of OSO. Firstly, there's a lack of consensus in its measurement and definition. So for example, for obesity, this can be measured either using DEXA, BIA, and anthropometric measures such as body mass index or waist circumference. And in sarcopenia, different definitions along with their different cutoffs have also been used as well. So at this juncture, the few general things that there's little evidence to really support the additive or multiplicative health impact of OSO. And there are three reasons cited for this. Most importantly, I think there's a paucity of direct comparison studies with overlap syndromes such as sarcopenic obesity, osteosarcopenia. Secondly, most of studies are cross-sectional, lacking longitudinal data. And thirdly, there's also a lack of clinical pathological correlation with blood and body composition biomarkers. So in this critical review by Yugenbo et al., they actually put forth the case that it's not surprising that these three conditions overlap because they increase with age and they share common risk factors. Although there is evidence for the partial overlap, a causal relationship is yet to be established. And importantly, as mentioned, because of the lack of direct comparative studies, it remains to be proven whether the concurrent existence of sarcopenia, osteoporosis, and obesity really leads to an increased risk of adverse outcomes above and beyond the risk associated with the sum of the component parts. And they therefore conclude that it's insufficient evidence at this juncture to support the discrete clinical entity of osteosarcopenic obesity. So against this backdrop, in 2017, the GYLabs 2 longitudinal cohort study, which is actually part 2 of the first study, was kind of formed with the goal of developing a clinical biomarker phenotype of sarcopenia and OSO to predict the risk of frailty or function decline amongst completely dwelling older adults. So we assembled a team of multidisciplinary experts, and our goal was to kind of develop a deep phenotyping of OSO through serial measurements of clinical, blood, and body composition biomarkers. And our criteria was basically those aged 50 and above, complete dwelling, functionally independent, and cognitively intact. And in wave 1, the baseline, between end 2017 and 2019, we recruited 230 subjects. The goal was to have annual follow-up, but due to COVID, wave 1 data was incomplete and the study was stopped for 6 months. So for this presentation, I will essentially be presenting wave 2 data, the 2-year outcomes between 2021 and 2022. And we have about 193 or 84% of subjects who completed full assessment, including physical performance assessment. So this to give you an idea of the cohort. Mean age of 67, predominantly females and Chinese ethnicity, and consistent of very well cohort. The median SPB score is actually a max score of 12, and none were frail when we use the Morley frail criteria of 3 or more. So essentially, this cohort is not representative of the typical national cohort, but it's a cohort of fairly healthy older persons. And what we hope to do, therefore, is that we really want to compare between OSO and overlap syndromes. And our research question would be amongst healthy, complete dwelling or Asian older adults, what is the relative prevalence? What is the association with blood biomarkers and body composition parameters? And lastly, what is the predictive value for 2-year outcomes? So let's review AIM-1. We use a DEXA-based definition. So pregnant lean mass for sarcopenia, fat mass percentage for adiposity, and bone mineral density for osteopenia, osteoporosis. And we use the validated Asian cutoffs as shown. So depending on the number of components, 0 to 1 would form our reference group. Overlap syndromes will have 2 components, and OSO is when all 3 components are present. Reviewing the prevalence, using the osteopenia definition, this is about 35.2%, which has a slight male predominance. When we use the osteoporosis definition, the prevalence kind of dips by about 3-fold to 12.2%, again with a slight male predominance. When we look across the age band, this jumps in the 50 to 60 age group from about 6% to about 13%, and this remains constant throughout the age bands. So we can see that OSO is prevalent even in a very healthy cohort of complete dwelling older adults. The definition matters. If you use osteopenia, it can be higher by about 3-fold. Interestingly, we have a slight male predominance. So this kind of differs from earlier studies, which were mainly done in post-menopausal women. But the male predominance was also reported in the Tianjin study. So I think more studies are needed in order to understand really if there is a gender difference. Next, let's review the relative prevalence. And this Venn diagram basically shows a distribution of cases through the overlap of the three conditions. So when we have a osteopenia definition, what you find is that the osteopenia circle has most of the cases, right? So the highest prevalence will be OSO, followed by osteosarcopenia, and also osteopenic obesity. However, when we use the osteoporosis definition, the number of cases in the osteoporosis circle drops, and the cases are redistributed to obesity, sarcopenia, and sarcopenic obesity. In our study, we'll be using the osteoporosis definition. So for overlap syndromes, majority cases, about 3/4 are constituted by sarcopenic obesity, followed by about 1/4 with osteosarcopenia. And this is important to keep in mind later when we interpret the data. Okay, with that, let's move on to aim 2, the comparison between OSO and overlap syndromes. So as mentioned, we have 3 groups referenced with 0 to 1 components, overlap syndromes with 2 components, also with 3 components. Analysis is at 2 levels. First, the comparison of OSO and overlap syndromes against reference group, and then number 2, that direct comparison between OSO with overlap syndromes. We perform one way and over a post hoc comparison for the cross-section analysis of body composition and blood biomarkers, and for 2 outcomes, we perform logistic regression adjusted for covariates and baseline values. We have 3 groups of outcomes: body composition, looking at bone mineral density, appendicular lean mass, as well as fat mass percent visceral adipose tissue. For blood biomarkers, we kind of group them into 3 conceptual groups: insulin resistance with leptin, adenopectin, and HOMA-IR. Inflammation, we have CRP, MCP1, and TNF-R1. And metabolism, IGF-1, myostatin, as well as vitamin D. For 2 outcomes, we have muscle function, looking at strength and physical performance, activity level, looking at social activity, the French, physical activity, the IPAC-E, and life space mobility. And lastly, we look at health-related quality of life. So this is a comparison of the 3 groups. And what we can see is that for the OSO group, they are older, slightly higher education levels. Interestingly, in terms of anthropometry, they have lower body mass index, lower weight, and lower calf circumference. They are intermediate for hand grip strength and weakest for knee strength. No difference in terms of geriatric syndromes. Okay, so let's first review body composition. And what we can see is that for the OSO group, they have the lowest BMD, and this is significant for the comparison with both the reference group and also the overlap syndromes. When we look at the appendicular lean mass, what we can see is that the OSO group have the lowest as well in terms of appendicular lean mass, but this is only different compared with the reference group. There's no difference when compared with the overlap syndromes. And lastly, when you look at the adiposity, the OS group again has the highest visceral adipose tissue when adjusted by BMI and fat mass percent. This comparison is significant only when compared against reference group, but not against the overlap syndromes. Moving on to blood biomarkers, when we look at the group of insulin resistance markers, we can see that OSO group has the highest insulin resistance, as evidenced by higher HOMA-IR, higher insulin levels, and lower adenopectin levels, which is significant compared against both reference and overlap syndromes. For inflammation, somewhat surprisingly, OSO has the lowest level for MCP1 and also TNF-R1. And this is significantly different for MCP1 when compared against the reference group and overlap syndromes. Looking on to the metabolic markers, no difference for VITE. For myostatin, OSO has the highest level of myostatin. And this is significant when compared against both overlap syndromes and reference group. And for IGF-1, somewhat surprisingly, it had the highest levels. Typically, in sarcopenia, we would like to see lower IGF-1 levels suggestive of decreased anabolic effect. But here it's actually the highest, and this is significant when compared against both the reference group and also overlap syndromes. Okay, so a summary of that whirlpool of results. Against reference group, OSO is lower bone mineral density, lower lean mass, higher fat mass percent and visceral adipose tissue, higher insulin resistance, higher myostatin, but a bit surprisingly lower inflammation and higher IGF-1 levels. And for overlap syndromes, similar findings except for body composition-wise, there's no difference in the direct comparison for lean mass and fat mass percent. Next, let's move on to AIM-3, which are the 2-year outcomes. We'll first review the muscle function. There's no difference in terms of predicting SPPB less than 10 at 2 years. But the interesting part is actually in terms of strength. So for hand grip strength, what we find is that the OSO group predicts a 4-fold increased odds of weaker hand grip strength at 2 years compared to the reference group. But this was not so for overlap syndrome, so that is a significant difference. When we look at knee extension, we see a suggestion of a dose-response relationship. So for overlap syndromes compared with reference, this is about 4.5-fold, and for the OSO, this is about 7.3-fold of in terms odds of weaker knee extension at 2 years. When we look at clinical outcomes, there was no difference in terms of ability to predict clinical outcomes at 2 years. So no difference for health-related quality of life, lifestyle mobility, physical activity, as well as social activity. So again, a quick summary for both reference and overlap syndromes. Mainly the prediction is for weaker strength at 2 years, but not for physical performance, activity, and health-related quality of life. Okay, so let's try to put things together. I think in terms of prevalence, OSO does show an age-associated increase in prevalence even in healthy, generally non-frail older persons. I think our study provides proof of concept of some differences between OSO and overlap syndromes. For the composition, this is mainly for the decrease in the bone mineral density. Adiposity may be visceral adipose tissue, but not for LMI nor fat mass percent. Blood biomarkers, there is increased insulin resistance in OSO and increased catabolism. There's also increased 2-year risk of weaker muscle strength, relationship more clear-cut for hand grip strength and the dose-response relationship for knee extension strength. However, there's no difference in activity levels and QOL, and the so-called surprising findings of the blood biomarkers. We expected high inflammation and decreased anabolism, but what we found instead was that there were lower MCP1 levels and higher IGF-1 levels. So how do we reconcile that latter finding? It does appear that one possible explanation is that perhaps at the OSO stage, it is driven less by inflammation, but more by insulin resistance. And for insulin resistance, actually, there are 2 levels. And what is really driving the mechanism in OSO is the peripheral insulin resistance. So in peripheral insulin resistance, the IGF binding protein 1 levels actually drop. And because of that, there's an increase in the free or bioavailable IGF-1. And that may account for what we see. Contributing factors towards decreased IGBP1 levels will also be decreased inflammation, intermediate BMI because of the inverted U-shaped relationship, and very interestingly, decreased leptin. And these are what we actually see in our results. So that again may drive the IGF-1. So putting together the increased IGF-1 that we see is not so much a case of increased anabolism, but rather it may be actually a marker of increased peripheral insulin resistance. So let's go back again in light of the findings to the propositions put forth by Bo et al. I think we do support that finding that OSO is quite prevalent even in healthy older persons. We do provide more evidence of this clinical pathological association, mainly for bone, to some extent fat, and then from the blood biomarkers point of view, mechanistically, there seems to be increased insulin resistance and increased catabolism. However, in terms of outcomes, we're only able to show that it predicts weaker strength at 2 years. So this is more on the tenuous side. So if you put things together, we feel that at this juncture, there's still insufficient evidence to really support a discrete clinical entity of OSO above and beyond overlap syndromes at this time. But we have learned some things as a result of our study. So summarizing again, one, that OSO subjects may be older, with lower BMI, lower weight and calf circumference. Insulin resistance appears to be raised, as evidenced by increased HOMA-IR, decreased aminopectin, and possibly here we postulate increased IGF-1 as well, and increased catabolism as a result of myostatin. So this would then lead to increased visceral adipose tissue, possibly also, although we didn't do it in this analysis, the infiltration of muscles as well, along with a decrease in appendicular lean mass index. Studies showing that insulin resistance and increased myostatin may be a risk factor for decreased bone mineral density and osteoporosis. So in the short and medium term, in our case 2 years, that could then predict weaker hand grip strength, and perhaps with longer follow-up may then lead on to frailty and other clinical outcomes. So we would be hoping to analyze our wave 4 data, and with that we hope to see whether we're able to see more differences in the clinical outcomes. So I'd like to acknowledge the team, both the investigators and also our research support team. Also like to acknowledge our funder, Lee Foundation, our committee partners, and last but not least, all participants for making this study possible. Thank you very much.
Thanks, Professor Lim. I think this afternoon, the final session, we have a lot of things to think about. So initially we have dynapenia, pre-sarcopenia, possible sarcopenia, and sarcopenia. And the second one, we have frailty. And right now we have osteosarcopenic obesity. And last one, we have osteoporosis. So our last speaker is Dr. Shau-Huai. He is from Yunlin branch of National Taiwan University Hospital. He's right now assistant professor of our National Taiwan University School of Medicine. And also he actually, the study is sponsored by the National Center of Geriatrics and Welfare Research. He did a lot of publication in osteoporosis. So let's welcome him for this final talk. The talk is about unlocking a novel anabolic effect, synergistic benefit of sequential strong anti-resorptive osteoporosis medication. Let's welcome Dr. Fu.
Thank you. Thank you, Professor Chen. And good day, distinguished audience. I'm Shau-Huai from National Taiwan University, Yunlin Hospital. And I'm honored to be here with you today. I'm delighted to present our research on denosumab sequential therapy. And I will discuss the potential synergistic benefits of sequential strong anti-resorptive osteoporosis medications. So osteoporosis imposes a significant disease burden when accessed through the disability-adjusted life year, ranking closely behind lung cancer in terms of its impact on overall health. The high death associated with osteoporosis underscores the substantial health challenges and diminished quality of life experienced by individuals affected by this bone-weakening disease. So addressing osteoporosis is very important. Fortunately, after years of development, there are now numerous medications, and most of them have a great reduction risk of osteoporotic fracture by 30 to 70%. So we have many weapons. Among older anti-osteoporosis medications, the top performers in preventing fractures are teriparatide, romosozumab, denosumab, and zoledronate. These medications can prevent more than 60% of spine fractures. The first two are bone-forming medications, while the later two belong to anti-resorptive class. The three most well-known bone-forming medications are romosozumab, teriparatide, and abaloparatide. Romosozumab is an anti-sclerostin antibody with dual effect, promoting both bone modeling and inhibiting bone remodeling. Teriparatide and abaloparatide are both parathyroid hormone-related protein analogs, stimulating osteoblasts and fostering bone formation. And regardless of whether abaloperidol or teriparatide is used, both can significantly increase spine bone mineral density with annual increase of 8 to 10%. In contrast, romosozumab can increase spine bone density by as much as 13.3% in 1 year. The treatment of postmenopausal women with osteoporosis using teriparatide led to significant increase in cancerous bone volume and connectivity. It also resulted in improved trabecular morphology, favoring a shift toward a more plate-like structure and an increase in cortical bone thickness. These alternations in cancerous bone and cortical bone morphology are both benefit to our bone and also prevent the fracture risk. This figure illustrates the anabolic window associated with various anabolic agents, defined as the interval between the bone formation marker, P1NP, and the bone resorption marker, CTX. Teriparatide and abaloperidol are approved for 24 months. That means 2 years treatment duration, whereas romosozumab only approved for 12 months treatment period, partially reflecting the difference in their anabolic window periods. So although they are very strong anabolic drugs, but they cannot be used too long, only for 1 year or for 2 years. Denosumab is an antibody here to inhibit the receptor activator of nuclear factor kappa B ligand, RANKL ligand, and bisphosphonate, nitrogen-containing bisphosphonates stop osteoclasts from sticking to the bone by blocking a key enzyme and inhibit bone resorption. As we all know, denosumab and bisphosphonate have different mechanisms of action, and their half-lives in the body vary considerably. These factors have a profound impact on their residual effect after drug cessation, and we will discuss later. Throughout denosumab treatment, there was a consistent and persistent increase in bone mineral density, particularly in the lumbar spine, with no apparent plateau. After 10 years of treatment, lumbar spine bone mineral density can increase by up to 21.7%. However, after stopping denosumab, there is a rapid increase in bone resorption marker here, CTS, the green line, and above the baseline, which remains elevated for up to 2 years and result in a rapid bone loss in lumbar spine within 1 year. This is known as the rebound effect. After stopping alendronate, the blue line, CTS remains suppressed for 2 years, and lumbar spine bone mineral density remain above the pretreatment level for 2 years. So previously, we conducted a population-based cohort study published in the Journal of Internal Medicine to compare the risk of major osteoporotic fracture, vertebral fracture, and non-vertebral fracture among patients who had discontinued anti-osteoporosis medication. Our study revealed that discontinuing denosumab led to a heightened risk of major osteoporotic fractures, particularly vertebral fractures, and this elevated risk typically became apparent within 1 year after discontinuation and increased with longer treatment duration. For instance, here, after 1 year of denosumab treatment and stopped drugs, the major osteoporotic fracture risk would increase about 60% when compared to continued user of denosumab. And the vertebral fracture risk will increase to about 118%. And after using denosumab for 2 years, and we could see that the risk increased a lot, and the vertebral fracture risk will increase to about 258%. On the other hand, about the bisphosphonate who used for 1 year and stop, or who used for 2 years and stop, we could see that the fracture risk, although would increase a little, but also less than denosumab. So a recent review article in The Lancet cited our work and recommended not delaying the denosumab dose by more than 1 month. bisphosphonates, including alendronate and zoledronate, lead to gradual improvements in lumbar spine bone mineral density, although the increase is less pronounced compared to denosumab. Additionally, the total hip bone mineral density tends to reach a plateau approximately 3 to 5 years after the initiation of treatment. And osteoporosis medications have rare but serious side effects. Two notable rare side effects associated with some osteoporosis medication are a medication-related osteonecrosis of jaw and atypical femur fracture. And the occurrence of these side effects may rise with prolonged use, prompting recommendations for a drug holiday in patients undergoing extended bisphosphonate treatment. But drug holiday was not suggested in denosumab because we know it would cause a rebound effect to cause more vertebral fracture. So the summary of drawbacks of anti-osteoporosis medications, we could see that about anabolic anti-osteoporosis medications come with notably higher cost of treatment and making them financially burdensome for many patients. Additionally, these medications are typically suitable for only 1 to 2 years, only for short-term use, limiting their long-term efficacy in managing osteoporosis. And about anti-resorptive agents also have certain drawbacks, such as rare but concerning side effects like osteonecrosis of jaw and atypical femur fracture. And about denosumab, we could see that after stopping denosumab, it could cause a rebound effect, large bone mineral density loss, and fractures. About bisphosphonate, bisphosphonate was less effective in increasing bone mineral density and would have bone mineral density plateau after treatment for 3 to 5 years. So also the same review in the Lancet recommends investigating the effectiveness of various treatment sequences, including the incorporation of cycles with this sequence. So as Professor McClone emphasized, the management of osteoporosis necessitates lifelong attention, and the optimal approach should be personalized, often involving the sequential utilization of various classes of osteoporosis medication. He also personally recommended to use zoledronate toward the conclusion of the treatment cycle due to its extended duration of drug effect. So he also suggested a structured treatment regimen, proposing the initial use of estrogen to prevent menopausal bone loss and preserve trabecular microarchitecture. Following this, he recommended a 3-year intermittent alendronate therapy with a drug holiday of 1 to 2 years to sustain bone mineral density. Toward the later stage of life, he advised concluding the treatment with a single dose of zoledronate. However, the suggested treatment regimen may not be optimal for patients with initially low bone mineral density due to the limited effectiveness of estrogen and bisphosphonates in increasing bone mineral density. And many studies have already demonstrated a correlation between post-treatment increases in bone mineral density and a reduction in fracture risk. Therefore, when treating osteoporosis, if possible, we should treat the patient to prevent fracture, and if possible, we should try to increase their bone mineral density as well. So my question is there a treatment for osteoporosis, whether through medications or the sequential utilization of various classes of osteoporosis medications, that can achieve sustained increases in bone density, prevent fracture, and have minimal side effects? So according to our previous multi-center randomized control study, we recruited postmenopausal women or older men who had been received denosumab for at least 2 years. Participants were stratified and allocated into 4 groups, with Group A as the positive control, receiving denosumab for another 2 years. And both Group B and C and D received zoledronate during the first year, and during the second year, Group B shifted back to denosumab, and Group C received another dose of zoledronate, and Group D went on a monitor drug holiday. And here is the flow chart. We could see that the follow-up rate is 92%. And today I will introduce the result of Group B, because Group B received the zoledronate for the first year and then resumed denosumab in the second year. We found that there is a lumbar spine bone mineral density surge during the second year. We call it a catch-up effect following the resumption of the denosumab. A potential explanation for the catch-up effect could be the decrease in serum wrinkle ligand following denosumab discontinuation. In a recent secondary analysis of a randomized control trial, Solin et al. Observed a peak in wrinkle ligand levels 6 months post-denosumab discontinuation here. And the serum concentration gradually decreased over a subsequent 6 months, where the actual mechanism remained unknown. And this pattern could account for the enhanced response to denosumab in the second year of Group B compared with Group A regimen. So we already know that there might be a catch-up effect when we resume denosumab after 1 year of zoledronate. And we also know that when we compare denosumab with bisphosphonate, we found that the use of denosumab has a better effect on bone mineral density than bisphosphonate, and is less likely to reach a plateau. However, discontinuing denosumab poses a risk of rebound effect. In real-world practice, patients often face the need to stop the medication due to reasons such as dental treatment or COVID-19 or anywhere, presenting continuous treatment with denosumab a difficult strategy. So based on the results of our previous randomized control trial and the characteristics of different medications, we have formulated a treatment approach. This method involves the initiating treatment with denosumab as a foundational therapy to improve bone density. After 2 years of treatment, we propose switching to zoledronate for 1 year to mitigate the rebound effect following cessation of denosumab. And then we repeat this circle until the end. So we call this study denosumab sequential therapy 2. We enroll post-menopausal women or elderly men who had been on denosumab treatment for 2 or 2.5 years. Participants were stratified and assigned to 2 groups. Group A, as the positive control, received continuous denosumab for 7 years, and Group B received 1 year of zoledronate, then shipped back to denosumab for 2 years, then another zoledronate, then shipped back to denosumab for 2 years. And we maintained the cyclic pattern till 7 years. And every group we recruit 30 patients in each group, and we measure the bone turnover marker, including CTS and P1MP every 6 months, and also measure the bone mineral density every year. So this is our initial result. These figures illustrate the percentage change in bone turnover markers. Regarding bone turnover markers in Group A, it was observed that throughout 3 years of continuous denosumab treatment, both CTS, the bone resorption marker, and P1MP, the bone formation marker, remained stable because they all used a strong anti-resorptive drugs, the denosumab. However, in Group B, concerning the bone turnover markers in Group B, transitioning to zoledronate resulted in approximately a 20% increase in CTX and about 60% increase in P1MP. So there is a substantial elevation exceeding 60% in P1NP. And upon resuming denosumab, when we resume denosumab here, both CTS and P1NP experience a 20% decrease below the baseline. So they come back again 20% below the baseline. And then when we resume, give the denosumab again in the second year, the bone turnover marker became stable and then returned to baseline. So it's interesting here, there is a potential anabolic window emerges between the lines representing P1NP and CTX during this sequential treatment. The phenomenon might be attributed to a substantial activation of osteoclast precursors after stopping denosumab and followed by osteoblast activation due to a coupling effect. However, as osteoclasts digest zoledronate on bone surface, they undergo apoptosis and to inhibit the bone resorption. But maybe there are also some bone formation occur here. So the total hip bone mineral density steadily increased in group A over the 3 years period, just as previous data show in long-term denosumab treatment. In contrast, group B experienced a stable bone mineral density after treatment with zoledronate, and then there is also a catch-up effect. So there is a rapid increase in bone mineral density after resuming denosumab, so we call it catch-up effect. After 3 years of treatment, the total hip bone mineral density in both groups became comparable. And the pattern observed in spine bone mineral density mirrored that of total hip bone mineral density, where there was a laser increment in group B during the 3rd year. And it's important to note that the number of participants who completed the 3-year follow-up remained limited. The study is still ongoing. And the pattern observed in femoral neck bone mineral density differs slightly from the previous 2 sites. The increase in femoral neck bone mineral density is more pronounced in group B compared to group A. This findings is particularly interesting as enhancing femoral neck bone mineral density is recognized as a challenging aspect across various medications. So there are several potential benefits arise from employing this cyclic treatment. After discontinuing denosumab, there is a synchronized differentiation of osteoclast precursor and recycled osteoclast. So, and this phenomenon was leading to large bone resorption and became more pronounced after several years of denosumab treatment. In a post-hoc analysis of our previous study, a significant difference in lumbar spine bone mineral density was noted in patients who with prior denosumab treatment. We could see here, if the patient received denosumab treatment for 2 years or less than 2.5 years, after transition from denosumab to zoledronate, their bone mineral density remains stable across 1 year. However, if they received denosumab for more than 3 years and then went into our clinical trial, after transition, their bone mineral density would decrease a lot to 4%. Previous studies on the sequential treatment of denosumab with zoledronate reveal conflicting results, where a study in Greece showed an increase in lumbar spine bone mineral density after 1 year of drug transition. A study in Denmark demonstrated a decrease in bone mineral density after the same duration of drug transition. So, given the difference in prior denosumab treatment duration, while the denosumab treatment duration was less in Greece and longer in Denmark. And in Ferrari study, patients who received denosumab treatment for an average of 4.9 years were subsequently treated with zoledronate following strict readministration criteria. Within the first year, most patients receive at least 2 doses of zoledronate, with some requiring up to 5 doses due to specific criteria. Despite this, significant bone loss of 4% to 8% and the lumbar spine was still observed among groups. So this is also the reason that why we design our treatment protocol as 2 years denosumab, then 1 year zoledronate. So the other benefit of our treatment protocol is that we could increase enhancing the treatment flexibility. If the treatment goals are achieved, such as we setting the goal of treatment of osteoporosis for the patient with a T-score larger than -2.5 or -2.0, a drug holiday may be considered after completing zoledronate for bone density consolidation. This therapeutic break may alleviate concerns regarding rare side effects such as osteonecrosis of jaw or a typical femur fracture. Adopting a cyclic treatment approach, intermittent use of denosumab for shorter duration, only 2 years, minimize the concern of rebound effect. Another potential benefit is that in the course of osteoporosis treatment with anti-resorptive agents such as strong anti-resorptive agents, denosumab or zoledronate or some bisphosphonate, there are many micro damage may accumulate in our bone. This is the micro damage, and it would cause our osteocyte to secrete rancoligand to call osteoclast to repair it. But during the treatment, all these will be inhibited, especially in the denosumab, then cause many micro damage accumulate in our bone. And this accumulation potentially leading to conditions like osteonecrosis of jaw or typical femur fracture. So, but on the other hand, after discontinuation of denosumab, this unopposed rancoligand here, many rancoligand here, will also cause the osteoclast to activation and cause to repair the micro damage, but also cause bone resorption and loss of bone mineral density. So our cyclic treatment protocol, there is the anabolic window here, and we could release osteoclast precursor every 2 years to repair our micro damage and to cause some anabolic effect. So I think this cyclic treatment protocol is beneficial for our bone. Our preliminary findings indicate that cyclic treatment with denosumab and zoledronate at the very least demonstrate comparable bone mineral density performance to continuous denosumab with fewer potential side effects or concerns during long-term treatment. However, whether the bone mineral density can continue to increase steadily in the future requires a more extended time of follow-up, and also the fracture risk. And the final advantage is that the use of long-dosing drugs, either zoledronate or denosumab, promotes better drug adherence. According to our previous study, during the first year, patients using parenteral osteoporosis medication have better adherence compared to those with using oral medications. So the parenteral one is the color is orange, and the oral one is blue. And even in the second year and third years, the adherence is nearly double than the oral form. So our protocol composed of 2 long-dosing drugs, including denosumab and zoledronate. We think that it will improve whether in the real-world practice in the future, it will cause a better drug adherence. There are also several potential drawbacks to consider. Firstly, although we anticipated that our cyclic treatment could periodically repair micro damage, the presence of residual bisphosphonate within the bone might potentially increase the risk of osteonecrosis of jaw or a typical femur fracture. Secondly, there is a potential for increased fracture risk due to the fluctuation in CTX and P1NP. However, no elevated fracture risk has been observed currently in our study. We could see that in Group A, there are 3 people suffer from low energy fracture and only 1 in group B. So currently there is no evidence that when changing to group B, that it would cause more fracture risk. And finally, we could still found in real-world practice or in our clinical practice, the patients there is still issues of medication discontinuation during the treatment period. Nevertheless, even in such cases, the cyclic treatment condition appears to better control the rebound effect. Additionally, previous literature has suggested that in individuals who have previously used bisphosphonates and then discontinued denosumab had a low risk of fracture and experienced less bone mineral density loss. So my conclusions are the sequential treatment with denosumab and zoledronate results in continuous increase in bone mineral density. Other benefits include a potential anabolic effect and periodic repair of microdamage. These benefits position this sequential or cyclic treatment protocol as a lifelong option for treating osteoporosis. And longer follow-up and studies focused on fracture are needed in the future. Thank you for your attention. We look forward to welcoming you to Yunlin County in the future. Thank you.
Thanks, Dr. Fu. This is a very new concept. So we will welcome all the panelists to go on the stage. And then we also welcome all the audience if you have any questions. So during the preparing stage, because I'm also doing osteoporosis, let me ask Dr. Fu for the first question. So for Dr. Fu, the reason why I think we try to use zoledronate several doses after denosumab is when you reach maybe to the goal, we will try to let the patient have holidays. But then when you use this cyclic pattern, there will never be a chance for the holidays. So then what's your strategy?
Actually, according to my design, I would follow the patients who reach the goal, maybe minus 2.5 or minus 2.0. And after the final consolidation of zoledronate, I would suggest drug holiday after the consolidation of zoledronate. Because only short-term denosumab used, and according to the Greek study, they follow their patients who use short-term denosumab and then a zoledronate for 3 to 5 years. Most of the patients who keep their bone mineral density during 3 to 5 years. So there's still a chance for drug holiday.
Thank you very much. So.
That was very interesting. I have lots of questions, but I know it's the last session. So I will start with a question to Dr. Fu. I think that's a very interesting study. However, I have a comment and a question. My comment is regarding the side effects. I don't expect that just switching from one anti-resorptive to another is going to decrease the risk of side effects because both of them are associated with osteonecrosis of the jaw. So I wouldn't put my money on that. But the question regards to the anabolic window. How can you find, what is the biological basis of an anabolic window there if both of those drugs are strong inhibitors of osteoblasts? In both of them, the osteoblastic activity goes down. We know that the increase in bone density is not due to anabolic effect, but the increase in bone density is due to secondary mineralization. So how do you demonstrate that is due to some kind of anabolic effect?
Initially, I organized the concept is based on the performance of P1NP and CTX. So I also try to find some basis for this difference in P1NP percentage change and the difference in CTX percentage change. And finally, I proposed that there might be a reason that's due to the coupling effect temporarily. because after cessation of the denosumab, there's lots of osteoclasts that would osteoclast precursor, they will become activated. And then because due to the coupling effect, the activated osteoclasts would also activate lots of osteoblasts. And because we have the sequential treatment with zoledronate, so the activated osteoclasts would digest the bisphosphonate and become apoptosis. However, the osteoblasts, they were activated by the coupling effect, and maybe there is a short-term for their work on our bone. That's just my hypothesis. I have no evidence to prove that. But I also agree that maybe the increase in bone mineral density will cause from the mineralization. So I just propose a hypothesis. I have no proof.
Yeah, because both of them are strong inhibitors of osteoblastic activity.
I know, yes. So it's interesting why there is different effects between the bone-forming marker and the bone resorption marker.
Okay, any questions from the audience, please? Professor Chen.
I have a question to ask Dr. Obuchi. Because your idea is very attractive, you using digital wearable device, right? And try to decompose the activity into walking or conversation. So my question is two. One is, did you ask the participant to have some diary so you can somehow to verify whether your judgment is correct or not? A second is, this type of study probably highly cultural context dependent. For example, in Taiwan, many elder people in the morning, they gather together in the park. They do some Tai Chi, right? But not by walking. But they maybe also get together doing some dancing, like a Thai dancing. But then they have a lot of chit-chat. And so I'm wondering, in that situation, do you like to, decoding a conversation or exercise without walking or something like that? So I'd just like to have your comment.
First question is how to verify whether the person speak or not, right? So because we have the cohort study every year, from that the questionnaire, I am planning to ask them the lifestyle, so that we can verify the part of that aspect. And the second one is, my idea of why I would like to use this kind of system is most of the study trying to find the physical activity to the frailty is more focused on leisure time activity. But in Japan, not many people, especially in the women, participate to the leisure time activity. But most of them are very busy during the time, because they have to have the household things and communicate with the persons. So the conventional type of research could not find that kind of the activity. So since this system is used for the cardiovascular the activity, but I would like to that the intensity of that activity is not so important, but how scattered the movement the activity is. That's my idea. So maybe you can use the person who are not actively participating Tai Chi, but if she or he has more activity with the person or talking to using the phone, you may understand the significance of that kind of activity by using this kind of system.
I have a question to follow that question to Professor Obuchi. Actually, I'm quite interested in your digital marker, especially the map. And so in your data, you also mentioned about the energy expenditure and the metabolic rate is, I recall, is related to Frailty score. Is that right? And so your map is a combination of working speed and energy expenditure, or just leisure activity alone. And because if that also related to energy expenditure and the metabolic rate, seems to me is back to VO max, similar to Jim Wang just mentioned previously about cardiorespiratory fitness. You also asked a similar question about walking speed. Is any data to echo this to concept? Walking speed and your cardiorespiratory fitness?
That's true. If you see like energy expenditure and walking speed, you feel like two are different. But looking for this kind of the older people, most of the energy expenditure is coming from walking. It's do you know the METs, right? So the person's the average level of the activity is about 3 METs through the 4 METs, which is not kind of more significant exercise for the cardiovascular things. To me, energy expenditure and walking speed are almost equivalent. So I did not that much attention to the energy expenditure in this presentation. But from your point of view, I understand that it could be different. So I'd like to do more research on that difference. Thank you very much.
I have 2 questions. One is for Dr. Kao. You present the trajectory of the sarcopenia, dyspnea, and the robust, but I wonder if your data is only analyzed for the cross-sectional data or longitudinal data. I remember you said that the data collected since 2015 and follow up until now, right? So I haven't seen you present the trajectory pattern from the robust to dyspnea and to sarcopenia. Do you have this kind of data? Or you mentioned that the leptin had do something about the muscle mass or muscle function. Do you see the longitudinal effect for the leptin? Okay, and for the second question is to Professor Obuchi. I remember you said that the accuracy for your digital biomarker is only 60% only. I wonder, do you stratify by your participant by their adherence or education level? Because we know that not every older people is willing to wear their wearable device whole day. So I wonder, maybe some of the adherence is better, then the accuracy is much better. And for those lower adherence, maybe the accuracy is lower. Thank you.
Okay, thanks for Professor Xu's excellent question. Actually, I presented my longitudinal data last year. And because today I just want to present the body composition or profile and association with muscle function delay. And in the longitudinal data, we have collected about 1,500 participants since 2015. And we can see a trend because we enrolled different muscle health status. And we continue to observe the robust participants for the following years. And we found that most of them will transition to the thalassemia process. And then the second one is transmitted progress to the thalassemia progress. And very few of them will progress to the sarcopenia directly. Because we observe it every year. And so we can see this trend. And the most important is all of the participants progress from robust to thalassemia. They tend to stasis in this status. They no further to progress to the sarcopenia. Maybe because in my concept and in my study, maybe this kind of groups tend to be more nutrition, more obesity, more fat. And make it, because we know that a little bit obese may be better for the old people. So they can sustain in this thalassemia process. The other one is the second process is robust transmitted to to the thalassemia pre-sarcopenia program, pre-sarcopenia condition, and this condition is much leanness, and then the other population, and because they have a shrinkage of muscle mass first, and if they have poor exercise, they will progress to sarcopenia very fast, faster than the thalassemia. And in terms of the leptin, I just follow up for about 1 year to 2 years. So I have no continuous follow-up to this leptin level. Maybe in the future work, I can continue to collect this data. Thank you.
Dr. Obuchi.
Thank you very much. First, I have to apologize that I didn't clearly describe my research. The data I have shown is that all from the person used this system for 3 months. So the other they can't adhere that our protocol is excluded from the analysis. Actually, that person is not so many. From the 1156 participants, just only 83 persons are excluded because of they could not adhere that the protocol. So I think at the beginning we thought the person don't like use this system because they are old, but in fact they like it, very like it. Actually, it's coming about a year till now. Over the 65% of the people still using the system. So I think the adherence is not so bad. But I recognize that the education level or some kind of factors may affect to this kind of information. So I will analyze more deeply. Thank you very much.
Please.
Okay, thank you. And I want to ask you, Dr. Shiong. Sorry. My question is about the definition of osteosarcopenic obesity. So, as you know, in European guideline on sarcopenic obesity, the muscle mass is adjusted with BMI, and also they included for obesity, they included waist circumference. So, what do you think about that, especially for Asians and in Singapore, your study?
Thanks very much for the question. I think when we perform the analysis for our study, we base it on the work of the original authors who basically just use a DEXA-based definition. So because of that, we use ALMI, which is adjusted for height square for sarcopenia. So BMD as per normal. And for fat mass, we use fat mass %. So this is conventionally the way that it's been done. But you're right. I think the key is in the definition, as I showed, right? If you use different definition, the prevalence changes, and I believe the predictive ability also changes. So coming back to your specific question, I think that it is important to think about the normalization of, for example, appendicular lean mass. Yeah, I think one of the possibilities why muscle mass has not been shown to be helpful could be because of the choice of measures to normalize. Yeah, so in particular, I think in Singapore, we are seeing a society where obesity is a bigger problem than malnutrition. And in my cohort, where the mean age is about 67, I think that group obesity is an issue. And I suspect it's very similar to Dr. Kao's group, where the dynapenia is actually, I suspect, dynapenic obesity. It's actually sarcopenic obesity. So in that group, what the studies have shown is that height square is not such a good way of adjustment, because with that, we don't adjust for actually the weight and distribution, and people who actually have sarcopenic obesity actually are not accounted for. So someone who actually may be having a lower lean mass is not adjusted for that. So generally, I think BMI or weight may be better in the case of sarcopenic obesity. We have not performed the analysis yet in the context of OSO, but I think that's definitely something we can follow up with to see whether that changes the prevalence as well as the predictive validity. Oh yes, yeah. So I think that's a good point. So in our, not in this study, but we had earlier published before, we compared between 3 definitions of obesity. We use BMI, we use waist circumference, and we use DEXA fat mass index. The one that works the worst is BMI. It doesn't pick up and it doesn't predict. So actually BMI is quite useless in the Asian context, because even when we use the Asian cutoffs with the lower BMI cutoffs, it doesn't work. Yeah. It's then down to waist circumference versus FMI. And in our context, the waist circumference actually was slightly superior to fat mass index in that it could actually predict SPPB decline at 2 years. And what is important is the protocol. So if we look at waist circumference, there are different protocols. My hunch is that the protocol for metabolic will be different from the protocol for muscle. So for example, if you look at WHO measurement, it is actually midpoint, iliac crest, and lower rib. That measurement has been shown in one study not to predict body composition that well. So in that study, the best measurement protocol is actually 2.5 cm above the lumbricus, and that's the one that we use. So I suspect for waist circumference, a study that really needs to be done is to compare between different protocols to look at muscle outcomes. Yeah.
I think due to the time limit, we will end our session here, and we'll save 5 minutes for the closure by our Vice President, Dr. Chen. Thank you very much for all your wonderful talks.
I will present the...
Please, a moment, please. We highly appreciate the contribution of our speakers, and we invite the moderators to present, representing our institute, to present the gift and certificate to our speakers. So could you please come to the stage? And yes. Okay. Okay, thank you, Professor Kao. Thank you. This session has demonstrated the achievements obtained over the years. Thank you, Professor Obuchi. Thank you, Professor Lin, for extending our understanding with international experiences. Okay. Smiling at the photographers. Okay. Okay. Thank you, Professor Fu. We invite speakers and moderators to the front, and we can take a photo together. Okay. Please smile at the photographers at the center first. Cheese. Okay. Video is. Okay. Okay. Show your certificate. Thank you very much. Oh, thumbs up. Okay. Oh, okay. Push for. Oh. Okay. Say hi to the camera. Hello. Hi. Thank you all. Thank you, everyone. As we draw near the end of the 2023 International Conference, we would like to invite the Vice President of the National Health Research Institute, Professor Tung-Wei Kao, to deliver a closing remark. Let's welcome Professor Chen.
I think everyone will agree. The organizing committee of this conference really put together an excellent program for this two-day conference. And we have been listening to opinions or experience from experts from many different countries and different disciplines. And in fact, the scope of the topic is quite great. Right, so we cover from single biomarker, multiple biomarker, even neuroscience approach, and also we deal with disease burst, healthy or preclinical situation, or even touch upon the intrinsic capacity. Right, so it's quite comprehensive. Yeah, so. I think we really enjoyed this 2 days conference, but in addition to the organizing committee, I think everybody will agree. The staff of this conference excellent, right? So probably we should give a big applause to our staff. Yeah, they have been prepared in every detail to make this conference excellent. But although I said, this conference covers a very wide range topic. Nevertheless, the aging is so complicated. And this National Center, Research Center, National Center for Geriatric and Welfare Research is only established 2 years ago. And this is the second year conference. And the CEO of the center just told me they plan to hold annual conference. Okay, so I hope many of you can consider to come back next year. And before that, I'd like to tell you one story. Although we cover quite a wide range topic, but however, the aging may also have some non-physical or non-medical aspect. I remember I heard Professor Ichiro Kawaji tell a story. That story is about the elder people who attend a golf club in Japan. And he divides the participants into 3 groups. One group is very typical long, early bird. They went to the golf course in the early morning, follow rigorous the golf, and then spend little time for social activity. So they keep their body healthy. The second group is they don't like to do the exercise, but they went to the club to meet old friends and then have a good meal and chit-chat. And the third group is they not only follow the rigorous exercise, but also have social activity, right? And so that Professor Kawashi followed those 3 groups and guess which group had the worst outcome? The first group. That means, even you don't like the exercise, but you will enjoy the social gathering. You have the same benefit from people who do exercise and do social meeting. So the take-home message is this. Even you don't know completely the academic language of the conference, but you enjoy the social gathering, you still have good benefit for your health, okay? Yeah, so remember, come back here, and we will have more attractive topic for people to share. And with that, I hope you have a safe trip back home, and also continue to maintain your healthy lifestyle and to have a good health and spirit. Thank you.
Thank you, Professor Chen. And once again, we would like to express our appreciation to the speakers and moderators. Your collective efforts have made this conference a great success, and we have celebrated together. And we highly anticipate promising collaborations or outcomes that will emerge from this event. Once again, we appreciate your continued support and look forward to your continuing involvement in the near future. And until we meet next year, see you next year, and thank you all. Goodbye. And the final. Please go on the stage, and can we take a group photo for all of the participants who remain at the last?